So, good afternoon, everyone. It's Nancy White, CEO of Inagene Diagnostics, and welcome back to the Healthy Helix. Today, we are delighted to have a special guest, and that is Jane Sarahson-Kahn. She is a health economist and also the owner of the Health Populi blog. It's a fantastic blog if you haven't checked it out, and we will give you the link for that at the end of this recording. So, thank you, Jane. Welcome, and happy to have you here today.
Nancy, I'm delighted to be with you for sure. Thanks for the invitation.
So for our listeners, Jane is based out of the United States, and as I mentioned, is a health economist. Jane, it would be really helpful if you could help people understand what exactly is a health economist.
Right. Well, everyone knows what health is, I hope. And economics is really the study of scarce resources, is really the definition we go back to in economics. So when you think about health economics, we think about how do we allocate scarce resources for the whole continuum of care, from prevention and public health to acute and chronic care downstream. And that's where the interesting discussions and debates happen, is how do you actually allocate scarce resources, that is money and labor, capital, and then workforce. And that's what we think about. We think about how we allocate the money in terms of spending, and then what the outcomes are from that spending. And we think about things like cost effectiveness, cost benefit, and even return on investment, because some of us in our lives have to calculate the value of life. You've heard about that in courtrooms doing that, and that is an element of what some health economists do. It's not really what I do. I think more about the whole ecosystem of care and how to be as efficient and effective as possible, with a real design sense for consumers for self-care. So I kind of sit at this intersection of patients slash consumers slash caregivers, the noun of the health system, the person, and then technology, economics, and policy. Those are sort of my wheelhouse areas.
And I mean, talk about an intersection of really critical, but also at times very disparate topics. But so important to look at it holistically. I'm just curious, what really inspired you to start this blog?
Well, we first asked the question, what inspired me to do health economics? And then the blog kind of follows from that, given some of my DNA and genes pertinent to the role that you play in healthcare and pharmacogenetics and genomics. I grew up with two wonderful parents in Detroit, not far from Canada, across the tunnel from Windsor. My mom was born in Ottawa, in fact, so I'm half Canadian by blood. Anyway, that mom, Polly, was diagnosed quite young in 1971 with a form of leukemia that was quite rare at the time, and for which there was no chemotherapy. And long story short, she lived actually 8 years beyond her prognosis, 6 really good years under the circumstances, and then 2 tough years at the end. So I grew up with a very engaged patient as a mom, a loving person, a person who took advantage of her social network, her clinical network, partnered with doctors, early adopter of nutrition for health, reading the books of Adele Davis at the time. She was early in this. She's sort of the, we have a lot of that now, but there wasn't a lot of it then. And there was no internet then. And then fast forward to my dad, who lived till he was 86. My mom died at 58. And dad was a bionic man, all heart related stuff, but did really well managing through diet, exercise. So I had these 2 engaged patients for parents, pre-internet, post-internet. In the era when my mom was sick, growing up with that, after she passed away, I looked at the health insurance data. I was a curious young girl and good at math at the time, and looked at what we call now the explanation of benefits in America, which says how much did it cost, how much does the patient pay? And my father had very little responsibility to pay that bill. My mother was a member of a labor union that covered healthcare to the nth dollar. Again, Detroit at the time, heavy union contracts through the auto industry, et cetera. And long story short, I was curious, who the heck's paying this bill, which at the time was over $100,000 in 1978, which was a fortune.
Yeah.
Especially for the last 13 days of care in hospital, which shouldn't have been that way anyway, should have been at home, palliative, etc. Anyway, I was entering college and studied economics, pure, regular, plain old economics, and then worked for a few years and went back to school to University of Michigan, my alma mater, to do a degree in health economics, which was pretty early at the time. We're looking at the early to mid 80s. Now it's pretty mainstream. And that was the beginning. So the blog came about because we have a lot of writers in my family, in the Sarahson family, with the last four letters S-O-H-N, Sarahson. And there's just a writer's gene, and it's very easy for me to write and weave trends together. And so in 2007, the blog goes back to then, one of my close friends, colleagues, Matthew Holt, was the founder of the Health 2.0 conference in San Francisco. And Matthew and I did a lot of forecasting work together at Institute for the Future, based in Menlo Park. And Matthew founded arguably the first healthcare blog, which is called thehealthcareblog.com. He owns that URL, which is a very
simplicity is beautiful, isn't it?
Yeah. So he inspired me to get going on this with my voice in this unique area. And he said it could take a lot of time, so don't get sucked in. Anyway, we're looking at 2007. So 14 years later, it's pretty amazing. I have thousands of followers on my RSS feed, and I get a lot of social media love for the blog and for my handle on Twitter, which is Healthy Thinker, since my company is called Think Health. So I'm Healthy Thinker. So yeah, it's very organic. And I love doing it. It's a lot of work, but I share it freely. I take no ads and I take no blogs from anybody. It's my voice and I keep it extremely independent.
No, it's fantastic. And I'm actually a new follower of yours, which is how our relationship came to be. But I was just fascinated by some of your opinions and topics and how you were assimilating data and really making it digestible for any user who just has a curiosity about some of the topics. So again, we'll share your blog link with our listeners at the end of our cast today. But really thinking about the last several posts, and you are quite a prolific poster. I certainly enjoy when I find a new post in my inbox. Really thinking about where we are in this period of COVID. I mean, certainly unprecedented times. I'd gone back to kind of look at some of your earlier entries in the blog, and there's certainly a proliferation and it feels like an acceleration of certain topics and trends right now. And I'm wondering if you can share with our listeners some of your thoughts around this COVID environment, where we are today, and what you really see as some of the trajectory of the direction we're moving in.
Right, Nancy. I mean, that's everything to me right now is this. My last flight on an airplane in 2020 was February 29th. Last year was a leap year. I flew home on the 29th from 2 meetings in San Diego. I'm in Philadelphia, by the way, which is my US home. And I also have a home in Brussels in Belgium, where I haven't been since before that trip to San Diego. So over a year with our beautiful empty apartment in Brussels. I had been meeting with Scripps on the 28th. Eric Topol, a very famous doctor who's arguably, one of the great digital doctors who communicates prolifically, especially for a doc. He's a good friend, and we met on the 28th, the day I flew out. And the 29th in the morning, I'm telling you the story for a reason. It was my COVID de-virginity, if you will, because I'd met with the Sharp healthcare system based in San Diego, 300 some of the top doctors and the clinical staff in the group, to orient them on this new health consumer in America. What demands does she and he have? Mm-hmm. And introducing me as the keynote that morning, the 29th, the CEO of Sharp, interrupted me before I started speaking to say, Jane, I have to make an announcement. And he informed the 300 plus key physicians from the SHARP system to conserve use of disposable masks and gowns because their supplier in Wuhan, China, 3M, had a supply interruption of PPE. I'm using quotes in case no one can see this. I had never heard the three letters PPE before in my life, and I read everything every day. You know, I'm a data junkie. PPE was a new acronym for me. So he was letting everybody know they had their first case that might have been the coronavirus in San Diego. The blood supply at the American Red Cross had shown some coronavirus in the blood that the Red Cross had. I flew home and I gave my speech and I flew home that day. And all these docs are hugging me and kissing, you know, like it's kumbaya. And I'm breathing. Anyway, I come home and I'm really sick. My husband's in Brussels at the time, and I may have had COVID. We don't really know if I had it, but I was unwell with that elephant chest thing. Anyway, Robert was in Europe, in Brussels, March 18th. I'm watching Rachel Maddow's show on MSNBC. Some of the listeners may know that. And she has on this guest, Laurie Garrett, who writes about pandemics. She's a Pulitzer Prize winner. And Laurie looks in the camera, like I'm looking at you now, and through Zoom. And Laurie says, I want all of you listeners to answer two questions right now. Where do you want to be for the coming months, and who do you want to be with? Because you will be in that place for a long time with whoever you are with for a long time. And I waited a couple hours for it to be morning in Belgium. And I called my husband on his cell and I said, you better get on a plane because I want you here with me. I can't come over there now. Sure enough, they shut down Belgium Air on Friday. He flew home the 20th through Newark, New Jersey, and took an Uber back to Philly from there. So, I mean, I then spent March 1st through about the first week of September, Nancy, consuming data from Nielsen on consumers. And you've read some of my blogs from wild places, all kinds of data on people, on technology, and of course on the coronavirus, and then popular trends for, you know, people loving Lysol and Clorox and fear of going out. Anyway, the second week of September, I published a book called Health Citizenship, which is very American in its theme, but the trends are the same in Canada and around the world. And they are the following 5 things we observe and will persist going forward. And the first one is the digital transformation of people, of the person. Older people at Easter and Passover, that Holy Week last year, which we just repeated a couple weeks ago, Passover and Easter, older people doing Zoom, Microsoft Teams, Google Hangouts with grandchildren, subsequently reading to kids and being open to telehealth with doctors. Big digital divide closing. This is a gift of the pandemic. We have many gifts. One is that older people are online, accessing telemedicine, telehealth, and more curious about the digital world. So that's one thing. Then more DIY, doing things ourselves at home, because of course we couldn't go out. Some of us still can't, depending where we are listening right now. So of course there are these Instagram pictures of sourdough bread from around the world, people baking, and yeast in shortage for a couple of months. In the bakery shelf, flour couldn't be found for baking, but people cooking who never cooked before. And at the same time, subscription meal programs going up in growth because a lot of people just didn't want to cook from scratch. The third trend then, if we're DIYing everything at home, we're DIYing health at home as well. And so really radical self-care beyond sort of Gwyneth Paltrow goop stuff. We're looking at self-care for mental health, and we'll talk more about that later, I'm sure. Self-care beyond what we used to use telemedicine for, which was triage. Should I go to the ER or not? Teledermatology. But the real shock and excitement in telehealth at home has been mental and behavioral health uptake, because it's been so poorly served and undersupplied from an economic point of view. We don't have enough therapists to go around, and geographically, they're in big cities, but not in exurbs or rural areas. So we've seen a take up of mental health and behavioral health, and that has persisted more than other forms of care. But we've seen telehealth across the whole continuum of care. And then two side effects that have been toxic, which is the mental health then, from quarantining, physical distancing amongst young people and older people who are isolated. And then the other toxic side effect, particularly in America, though in parts of Canada and certain populations, is financial. People losing jobs. And in the US, we have what we're calling, we economists now on the economics front, a she-cession. So it's a recession amongst women who have been hard hit in the pandemic, couldn't go back to work, lost jobs, or forced to educate kids at home. Much as we love our kids, there are jobs waiting, and some women could not go back to work because of that. So those two side effects, mental and financial, will persist over time, because women have not made the same wages as men in terms of, wage equity. And we lost ground in the last year, significant. It will be a hit on women's retirement income, long run.
Yeah, I mean, I just love how you have such a diversity of topics and angles that you cover, and it really is far reaching. I laugh inside because I saw a meme just this morning on the internet. It was by a female, and it was just kind of a funny blurb about looking for work post-pandemic, and basically saying, being a single mom at home, managing all these accomplishments in my current role while taking care of my small child, imagine what I can do in the post-COVID workplace. And there's certainly lots of stories of inspiration. However, we have got a lot of other stories on the other side of that equation. And it's one of the things I'm grateful for is that there is more of an appetite for people to listen and dialogue about issues that have been there before, but in fact have been worsened and amplified through this environment that we're existing in.
Totally. Yeah. I mean, we talk a lot about systemic racism in America now, very openly. And in healthcare, it's been there in terms of health inequity, health injustice, which Martin Luther King talked about years ago as being the worst injustice of all the injustices. So this is an old problem, which a lot of us in health economics and public health have been talking about for decades. But again, the gift of the pandemic, which has been a bittersweet gift for sure, is that it's pretty mainstream to understand now what the social determinants of health are: education, housing, clean air, clean water, etc. And in Canada, you have your own issues with health disparities as well, Native populations and others. So this is a global challenge for sure.
Yeah, and so shifting gears a little bit, but really anchoring in on some of the points that you raised when we talk about the global issues. We briefly mentioned the mental health impacts and the acceleration, if not growing, wave of concern that's emerging. We see this across many age groups. Talked about in a variety of forums, but I'm very curious to hear some of your thoughts and opinions around this, what has been dubbed as an echo pandemic of the coronavirus pandemic.
Absolutely. I wrote about it very early on, March or April last year, because I do forecast and read tea leaves for a living. That's one of the, that's one of the things people pay me to do. And I wrote about it as the epidemic after the pandemic. You could just tell from quarantining that there would be people who would stay home and persist staying home and stay away from healthcare and stay away from family, maybe even longer than they might have to, which is where we are now in parts of America with vaccinated people, versus those who would never quarantine and who have used wearing a mask as sort of a political issue, not wearing the mask as libertarian or freedom. Now, those of us with public health degrees believe in loving neighbors and paying it forward by doing things like sharing data and wearing masks. But, this has brought out this chasm between people who believe in a collective and people who don't. And this is a reality. And that's why dialoguing as you're talking, as you mentioned earlier, is so important. And there is some greater empathy coming out now. Again, one of the positive things is more and more people understanding, I need to walk in your shoes and please walk in mine so we can come to some consensus agreement. With mental health, again, a good thing that's happened is some of the taboo is falling away from it now, because as it turns out, quarantining and the stay home, hashtag stay home, work from home, is really not good for anybody's mental health. We are social animals, and we think about our Maslow hierarchy pyramids. And if you've been on my blog, I use it a lot these days, because the pandemic, as I write, flattened our pyramids down to the basic bottom two and maybe up to the third level, the basic needs of housing, shelter, heat, warmth, food, and the search for Clorox and Lysol being, our cavewoman instincts at the bottom, building the pandemic pantry, which is what Nielsen called what we were all doing early last year. But you move up from that and you have safety and our psychological need to feel that we're living in a safe haven, which is where our homes have become for us in the stay home era. And then the third level is the social level. And that's where I bring Wi-Fi in as a social determinant of health, because if you could not leave home and you lived alone, you needed connectivity via broadband. And sure enough, so many people were caught out, couldn't go to school from home, couldn't socialize or work from home, couldn't attend church from home on a Sunday, because you couldn't go to a faith-based institution, for a long time. And even now, it's distanced and sort of anti what communion is, right? So mental health, I think post-traumatic stress, or just traumatic stress, little t, little s, we don't want to equate this necessarily with going to war, like my dad in World War II, death to the right, death to the left. He came home pretty shell-shocked in The Greatest Generation. But we all have a degree of this now. Every single person, and it doesn't matter how affluent you are, and if you have been working from home, because I know people with PhDs who are afraid to go out now, even though they've been vaccinated twice, 2 Pfizers or 2 Modernas in my neck of the woods in suburban Philly. We are so conditioned now to keep distance that what will it be like for my husband and I to have one couple over who's vaccinated, who are over 55, who are, well vaccinated and mature in the antibodies. And we love having big dinner parties. And, we're second thinking, how do we have a couple inside? So, I mean, and this is us with all the blessings in the world. So we know there's this continuum of stress, anxiety that's been documented by the American Psychological Association and others, which I've written about. And so, Nancy, it's affecting everybody in certain ways. And so we all need to find ways to hack our way through this. And there are many. Again, the good news is the pandemic accelerated investment in digital health and in healthcare technology in general. So a group I work with in Dublin called Health XL, letter X, letter L, like extra large after health, but they've been inventorying all the digital investment across every venue of digital of health. But they looked at telemental health middle of last year, and there are all these subsegments of virtual mental and behavioral health that is so exciting, from apps like Calm and Headspace that have really grown a lot, to really amazing VR and virtual reality, augmented reality headsets to help with true post-traumatic stress. that have been tested in the Veterans Administration in the US and others for people, say, like my dad coming home from World War II or Afghanistan or Vietnam or whatever. So it's very exciting to see everything from cognitive therapy, which I think everybody really needs. And I'm not a doctor, so don't listen to me as Dr. Jane. I'm not that kind of doctor. But cognitive therapy is very useful for seeing a glass half full in this moment, I think. So you're seeing lots of very effective cognitive therapy for mild and moderate anxiety and depression, and all the way through to this AR, VR stuff that Brandon Spiegel at the University of California, LA, he's one of the godfathers of VR and AR in health for pain, for mental health and such, and he's testing out a lot of the concepts. So it's an exciting time, though sobering, because it is that epidemic, as you said, introducing the question.
Yeah.
So it's our opportunity and our threat.
Yeah, it's, even for ourselves, we're just a 2.5-year-old company, but in the wake of the pandemic, we've seen our business grow exponentially. And we'd always been focused in pain and mental health pre-pandemic, but it was certainly an opportunity for us to accelerate a number of initiatives. So if there's silver linings to be found, we've, tried to really avail ourselves and make ourselves part of the conversation, but also part of the solution. And, again, I hearken back to a lot of your posts and entries over, at least the last 6 months on your blog, and really looking at some of the themes and trends around the new emerging technology, the adoption of it societally. I think that we're at a turning point where we've got to almost accelerate some of that implementation in some ways, because the waves of the crisis, I mean, there's always peaks and troughs to anything we deal with, but there seems to be an overwhelming sense, especially among the younger populations. And now that we're seeing that the new variants of COVID seem to be hitting this age group in a more substantial way than what we saw initially with, I guess, the original COVID. What do you see as some of the challenges for us, catching up with that pace of change, but also the intersection of adoption versus implementation?
Yeah, so I think some of the younger demographic looking like they're more likely to have a bad reaction to the variant, I think has a lot to do with lack of physical distancing and socializing and not listening to the public health advice. And I was young once, and I have a 24-year-old daughter who I think has done remarkably well, staying safe in all of this. But there is some of that sort of my free will to not distance. So the question was, how do we scale the solutions? It's instructive to look at what we've done with vaccine hesitancy in messaging. How do you motivate people through messaging the right way? And as we know from data that we've been reading about more recently, younger people are engaging with information and apps and digital health differently than older people. So while everybody's taken up telehealth, younger people don't really care if they ever have a medical home, like a GP, a family practitioner, right? Primary care home, versus just going online to either a commercial site like an Amwell or Teladoc or whatever, or through your employer or through your local health system, or through a peer-to-peer network. So if you have, colitis or a gut issue, you find other people like you in Australia and Germany, whatever, and you can crowdsource cures. And this has been going on for some time. I've been involved in that community for a while now. But now, again, it's exciting because it's gotten mainstream, because necessity being the mother that it is, we're looking to partner with each other. And a lens on that, which is really important, is trust. So what voices do you trust? Do you trust the people in government? No. Government has really fallen in trust in the Edelman Trust Barometer that's done every year. Do you trust the media? Not really. No, you might trust the media in your bubble, but even then, you really trust your own doctor. You trust your own sort of experts at, say, a local university. So in Toronto, you might trust people at the UT or McGill in Montreal or University of Michigan, my alma mater, go blue. But you trust local, and you trust people close to you who share your values. And that can mean other patients or peers in your own situation. So that's kind of exciting to think about. What is the opportunity to scale based on persona, the psychographic research on groups of people? It's not geographic. It's not necessarily even age necessarily, because we know there are some older people who are really hip, who belong to, AARP, the American Association of Retired Person, who are, aging with grace and excitement. And there are some young people who are gaming on their couch who will never leave their home. So interesting. You have to think about value and values and how are people living for scaling things. Early on, you talked about in the health economics section of our discussion, or maybe it was even before we started recording, payment and how do we sort of align incentives, to cover new innovations. And that's really the tough part of all this, because in health economics, some of us think about the whole ecosystem, which I do, the life cycle of mental illness, let's say, or mental wellness, and what's along 20 years, what's the payback. But health insurance plans are used to people coming in and out year or two. And so the incentive to invest in year 0-1 isn't that great, because you think, well, that patient will leave me or member will leave me in year 3 or 4. So we have to get away from that kind of thinking and paying for fragmented visits, pills, therapy, physical, occupational, whatever, and think about holistically what's best for that person. And that means changing the way we pay for healthcare in terms of value, not volume.
Yeah, I mean, you bring up so many amazing points, but I just really there's a question I've been dying to ask you, and it's really because, as you know, we operate a pharmacogenetic testing company. I'm dying to hear your thoughts as a health economist about the value of tools like this. And in particular, when we think, again, back to our example of mental health, the amount of trial and error that happens. And then there are, of course, downstream costs and impacts associated with that. So can you share some of your views on this?
Sure. Well, clearly, the more personalized treatment, generally speaking, it will work better. It will be more effective. And so we think about, again, I talked about cost effectiveness at the end of the day. If you add in the whole ecosystem, just of say an episode of care, so over a couple of years, okay, we're not going to look at a lifetime because that's not practical. But if we just look at this episode of a person, say in before COVID, with back pain, or with post, a pain after an operation, whatever. That's sort of this episode, looking at a matter of months, a couple of years, and how much all in are the costs of care, the visits to the emergency room, the visits to the doctors. We have to be really inclusive, and every line item, figure out what does it really cost. If I was writing a white paper on this, you'd have to, and making a model, an economic model, you inventory every cost of the inputs of care, every pill, every Band-Aid, every occupational therapy visit, mental therapy visit, psychotherapy, inpatient, home care, long-term care, blah, blah. Then we look at the benefits or the effectiveness. Did the person go back to work? Did they pay taxes? Maybe how much taxes did they pay? Right? How much did they contribute in the community? Did they participate in PTA? And we can impute, meaning estimate what financial value that had. And we have to get real about this. And we can do this. This is done. There are models for this. But if we look holistically at that episode, we can actually garner usually a return on investment that could be quite high. Because if we think about a digital therapeutic or a pharmacogenetic product that keeps people out of an expensive hospital bed, high capital intense environment, so they can go home, function, have a great sex life, live their life, all the things that a person values, all the love they have, community engagement. You really can look at the argument for funding this. In America, we have self-insured employers, big companies who pay for health insurance themselves and have a third party administer it. Those companies listen to this kind of argument because they're all in and they want to keep workers working, particularly in the pandemic. And there's a lot of mental health stuff going on and pain, musculoskeletal stuff, because we're not moving around enough. So I really think it's an exciting time for that. And if we think holistically, and we're starting to think more about value versus volume in the States, we hospitals and doctors who took on that financial risk before the pandemic and in the pandemic did financially better in the pandemic than those hospitals and doctors waiting for people to come in for visits because people weren't coming in for visits. They were staying away. So if you took on value and you managed those patients with apps and tools and telehealth to the home, you made money. And this is the American model right now. We're in the middle of this volume versus value, but it's moving quicker toward value because of the pandemic now. That's good for you.
Yeah, we feel very fortunate to be in the position we're in and excited to really accelerate and grow. Listening to your thoughts and your comments based on your diverse amount of experience has been so tremendous. We're really grateful that we got to connect with you. And I'm not even sure if a pandemic had happened, we would have found each other. But it's been a pleasure having you here today. And maybe next year we'll have you back and kind of see what progress have we made from where we are. But I really want to thank you for your time. It's been great meeting you, Jane.
And you, Nancy. Thanks for inviting me on.